Our topic today, as Glad suggested, is what's being done and maybe what's possible to provide health care for underserved Missoulians now in this recession, depression. And I'd like to mention that I started myself working on the issue of universal health care back in Madison, Wisconsin in 1991. And that's getting close to 20 years now. So before I introduce Dr. Hal Brown, who will introduce Ms. Kim Manch, I want to give you a little saying that is attributed to that very gutsy fighter against British colonialism, Mahatma Gandhi. And it goes like this. First, they ignore you. Then they laugh at you. Next, they fight you. And then you win. So, Dr. Hal Brown started his cardiology practice in 1955. 30 years later, he was given the job of chairing a hospital committee charged to develop the health, a plan to address health needs of the uninsured. From this plan, Partnership Healthcare Health Center has evolved. Hal is a longtime league member, and he'll introduce our speaker, Ms. Manch. Thank you.
Thanks, Jane. You have to be an optimist in this business for sure. I wanted to take a few minutes to set this in the historical perspective. And somebody needs to write this up. Maybe we need to do that. But back in 1900, the county budget had a line for the poor fund. And they clearly had an interest and a commitment in providing some care for the hardcore medically indigent. The next thing that we know of for sure is in 1945. In 1945, the public health nurses, some of whom were league members, I know, became much more sophisticated with well child screening, which is basically low-income children for parental neglect and nutritional needs. Physicians began to help with that after the war, and there was a return of some of the family practitioners and pediatricians who'd been in the service. George Barmeyer, Alderson, some of those names you must know. Leonard Brewer was very active, working at the health department in will child screening. There was a county physician when I came to town, and when that started, I'm not sure. But when I came, John Nelson was county physician who was charged, quotes, with furnishing medical attendance to the indigent, sick, poor, and infirm of the county of Missoula and the inmates of the Missoula County Jail, and to such other indigent persons as are designated to him by the Board of County Commissioners, Department of Public Welfare, for the sum of $800 a month, which includes auto expense. And that obviously was taken from a much older document in the county book of contracts. It's fun to go through that. In the mid-'80s, Dennis Lang was the health officer, and he gave this report to the physicians. We're getting grandparents and parents of these so-called well children who are showing up at the well child clinic, and they say, I need help with my blood pressure or my diabetes or my heart failure or whatnot, and my doctor won't see me anymore. People were going from doctor to doctor, were going from emergency room to emergency room, a terrible way to get comprehensive medical care. And so they were showing up at the health department. And he organized 20 or so physicians and nurses to help at the health department to see these adults who were coming to well child clinic. Well, then we got a new health officer, Ellen Leahy. And she quickly realized that that is never going to fly because the health department was so crammed. And again, it was inadequate and poorly planned, and he had no money for it. And that is not in the mission of the health department, to give indigent care. So the health board said, we're going to stop that in a few months. And that really energized the physician community to start planning coherently what can we do about this large group of uninsured persons. Well, fortunately, we had something to look back on. And that was this 1986 project that John Brown and some family practice and OB people had started. And they were concerned with the fact that a very substantial number of pregnant women were showing up for delivery and did not have any prenatal care. The prenatal care is 90% nutrition education, smoking cessation, get off drugs, take your folic acid, and fill out your Medicaid application. Now, Larry White, who until recently was chief at St. Pat's, tells a wonderful story of going down to the county welfare office and getting a Medicaid application. And he couldn't fill it out. It's too complicated, so many pages. And that's what the obstetricians were supposed to be doing in their office, which was impossible. So Access Links was a partnership between the public health nurses, the health board, and the physicians. And the health department, public health nurses, would take care of the educational and the WIC aspect and getting the people transported physically to get their papers together for Medicaid application. Anyway, that was a wonderful program, relatively small, but it was a model which then turned out some years later in Partnership for Access, which was dreamed of and conceptualized as something that would solve the problem. And John Brown, same person who had dreamed up that, was medical director, and it opened in November of '91, and we were so proud of Partnership for Access. Oh, our problems are resolved. And that lasted about 3 weeks because it was swamped. It was all volunteer, and what were needed were nurse helpers, social workers, psychiatry, dental care, overall executive management. The whole ball of wax was totally inadequate. So applications were put in '97, and the outcome was Partnership Health Center. Well, I think in this group, everybody has had a lot of organizational experience. And you know what organizational angst is in a new group that's inadequately funded and brand new. And it's my understanding that Partnership Health Center had a lot of organizational angst in its early years as it was getting off the ground, but always overloaded. And what I have heard is that just magically disappeared when Kim Mensch arrived as the new director, and I'm sure she's going to let us give her some questions, and I get to give her the first question, which is to ask Kim if you would tell us a little bit about your background. How did you get to be an executive director?
Yeah. Sure. I'm happy to do that, and I'm happy to be here. Thank you so much for having us. I was telling Dr. Brown I could just talk forever about Partnership. It's a great organization for us to have in Missoula. But I actually am from Missoula, and I went to school here, got an accounting degree, and got my master's at the University of Montana. I started out working at the Western Montana Clinic, and worked there for about 6 years. From there, went to the city of Missoula, all in the finance department, and worked at the city for about 5 years. Then when the partnership position opened up for their finance director, it was the perfect combination for me of the medical that I missed and a little bit of the government, but of course back taking care of people who needed to be taken care of. So it actually was a great transition in terms of my skills. I wouldn't say problems magically disappeared when I came. It was a tough time when I entered Partnership Health Center. We were going through some huge financial issues. Very, very compassionate people, but the system was just overwhelmed, and we didn't really have enough resources to take care of all of the people. So there were some pains that staff mostly had to respond to, where we had to just really get our business plan and get our house in order, making sure that wherever we could access revenue, that was being done. If patients could pay, that we were taking their money for them, billing their insurance companies, billing Medicare and Medicaid, and really reeling in our expenses. So it was a huge group effort that just needed a little bit of leadership. And so I stepped in at kind of a crisis time, but everybody really got on board and did what they needed to do. Then I was the finance director there for about 5 years, and then became the executive director just a little bit over a year ago. So having a great time doing it. So I have prepared a handout. It's a PowerPoint that you guys can just follow along on. And feel free to ask me questions during it or afterwards. I'm flexible however you guys want to do that there. So just as a brief introduction to Partnership Health Center, we are a 501c3 nonprofit organization. That's very critical as we talk about some of our funding streams and where we get some of our funding, and we'll address that just a little bit later on. But our mission is to provide accessible and comprehensive health care to the medically underserved residents of Missoula and surrounding areas in partnership with other community resources. So in a nutshell, we are the safety net for people who don't have resources to access health care elsewhere. We hope that they would turn to Partnership Health Center. Dr. Brown already gave us a brief history. My history pretty much starts at the beginning of when they started looking at developing partners for access. We're designated to become a federally qualified health center, which really is a trigger for federal funding, which again we'll talk about in our funding stream why that's so critical. Through lots of fundraising, events, all kinds of grants and whatnot, they were able to erect the building that Partnership Health Center is in right now, which is at 323 West Alder, right next to the health department. At the time, the building seemed huge. It's about an 11,000 square foot building, but we are bursting at the seams. And so we are taking steps to address that, and we'll talk about that later on also. We provide health care for anyone. We do not deny services because people can't afford to pay. But on the other hand, if people have insurance and they can afford to pay, we want to welcome them also. It's part of our business plan. It helps us diversify our funding streams. But everyone is welcome at Partnership. Nobody is turned away because of their income. We do provide services based on a sliding fee scale, and that can be confusing for some people, but the federal government has a federal poverty guideline that we follow for that. And I actually brought that today to kind of talk to you about that, because a lot of times people are out of touch on really what the federal poverty guidelines are. But for our purposes, assuming you were a family of 4, if you earned $22,050 a year or less, you're at the poverty level. And so your family would qualify for our minimum sliding fee scale. What that translates to is you or your family member could come in for an office visit, and the cost to you would be $12. If you had some lab services, other things, they're also slid down to $5. So We also take your income, and it's just not the minimum sliding fee scale and full fee, but we have brackets that fall in between there where we classify you. So you may have to pay 25% of the fee, 50% of the fee, or 75% of the fee, or full fee if you're 200% of that poverty level or above. The intent of a community health center is not to compete with the private industry. So we have strict guidelines on how we set our fees. We actually have to do studies in our community or access information where studies are done to see what those average rates are, and we're not allowed to undercut those average rates. But where the benefit comes in is we charge the full fee, but then we're able to slide it down based on people's income. So, and we have a variety of all of those fees for all of our services in our medical clinic, our dental clinic, our mental health, and our pharmacy. And the pharmacy is very, very critical. Some community health centers don't have an in-house pharmacy. Partnership is very lucky that they do, because what good is it to have a diagnosis but not to have any medication to treat people? We pretty much have a policy where our patients, we have a variety of programs, a variety of grants. If they have chronic disease issues or management that we need to help them with, they pretty much leave Partnership Health Center with their medication, with the exception of pain medication. We have to look elsewhere for that. Our governing structure is very unique. We are members, we're a component unit of Missoula County and a division under the health department. However, the federal government and our federal grant requires that we have our own board of directors. And our board of directors is very unique in that 51% of those members have to be consumer users or our patients. So it's a perfect avenue for our patients to tell us and communicate to us what they need, what's going on in the community, where they're having struggles, or how we can better meet their needs. So it's a very unique kind of board that's required by the federal government that is very enjoyable to work with. The other part of the board needs to be made up of community representatives, basically. We have representatives from both of the hospitals, Community and St. Pat's, who we consider very strong partners of ours, representatives from the county and from the city, and from various other groups, from the Missoula Indian Center, Missoula Aging Services, that make up all of that board. Currently, we have about 18 members on our board. So it has to be between 9 and 25 per the federal guidelines. So we're always right in there, but the key is the 51% patient majority. The board does have a lot of responsibilities for the health center. They have the oversight of my position, so I answer directly to the board. So they hire, fire, and do my evaluation. They also have to approve the annual budget and any grants that we submit. Again, this comes back from the consumer users' input. If they want us to be looking at Ryan White grants or Healthcare for the Homeless grants, they have the opportunity to tell us to focus in that area and approve those budgets and those grants. They also set they approve our fees, and they approve the services that we're going to do. And as well as that, they also are responsible for the hours of operation that we work in, any other general policies that we have to have in place. So they are very busy, very, very important to our structure. Many of you may wonder, how do we do this? How do we provide these services? Our budget right now is just a little under $5 million. And so that comes from a variety of sources. About 30% of it comes from grants. Our biggest grant, of course, is the federal grant, which is about $950,000. And the purpose of that grant is really to make up that sliding fee scale from the actual fee of our services on what we collect from our patients. That grant really fills in that hole. We have lots of other grants. We have a Healthcare for the Homeless grant that's also a federal grant. We have a Ryan White grant, and I'll go into more detail on those too, that make up that 30%. But we don't want to get into a situation where our organization is very heavily, heavily dependent on grants, because the grant goes away, then the services go away. So diversification of our funding sources is very, very important. The big part of our fees right now is about 61% from our patient fees. And what is grouped in there is our Medicare, Medicaid, some insurance, and then patient fees. Community health centers really want to take care of Medicaid and Medicare patients because it's much higher reimbursement and nobody wants to see them in the community. And so people think, well, I have Medicaid, I have Medicare, I have insurance. Not so if there's a provider that's not going to see you. The Medicare population is one that I'd really like to draw your attention to. And in the past 3 years, we've seen a huge change in that structure. We've had many physicians, primary care doctors, family practice doctors, internal medicine doctors retire or have transferred over to some of other programs where they don't see patients right in their office. It's been very difficult for their practices to absorb their Medicare patients because the reimbursement is low for them. So for the first time ever, Medicare patients we've seen haven't been able to access care and really couldn't understand why. And very complex cases, chronic disease, high blood pressure, diabetes, obviously cannot go without care. And so Partnership Health Center has really stepped it up and has really targeted those patients to help them out. In terms of insurance, we have about 10% of insurance patients. We also have contract revenue. We have a number of our programs where we partner with the county and with the state to provide some services. So when Dr. Brown mentioned the Poor Fund, that we still use that term today for some of the money that we access from the county. The county provides about $240,000 for a variety of our services that are intertwined through our whole county that comes from that base of funding that they still have today. We have a contract with the state of Montana to provide services for breast and cervical health screens. Another contract we have is at the detention center. Our dentists go out to the detention center and actually take care of some of the inmates out there. So we have a variety of contracts, state for the HIV prevention grants. So we always have those coming and going, but are very critical in terms of providing some services and a lot of preventative services too. So, so that makes up kind of our funding sources. In terms of expenditures, about 75% of our budget goes to salaries because we're such a service organization. So who do we serve? And I started talking about this a little bit. We refer to that as the payer mix. So about 61% of our patients are just uninsured. No Medicare, no Medicaid, no insurance, no coverage whatsoever. About 20% have Medicaid, about 8% have Medicare, and about 11% have private insurance. And the thing I will say about private insurance is Missoula is a high retail area. And so you do have people that have insurance coverage, but we classify them as underserved because their deductibles can be as high as $2,000 and $3,000 and $4,000. And when you see, if you're trying to support a family on $22,000 a year, it's very difficult to even begin to think about meeting your deductible. So we most definitely want them to come to Partnership Health Center.
What year are these, or what date are these figures?
Our payer mix?
Yeah.
That was as of December. Mm-hmm. Yes. Currently, right now, we serve about just a little under 10,000 patients. But to give you an idea, 77% are living at 150% of poverty level or below, and 92% are living at 200% of poverty level and below. So, so a huge number there. That number is going to go way up, and it has, and we felt that impact really since October, when the economic crisis has really been hurting. And to give you kind of an idea of, in Missoula County, if you look at roughly the 100,000, 110,000 population, the Montana Primary Care Association over in Helena does statistics on really what they would qualify as what the underserved are. And we serve 10,000. They predict that there's about 36,000 more out there in Missoula County that aren't, that qualify or fall into that category that need services of some type. And what you end up seeing happening there is people, when there's a barrier there for cost or for access, they just end up going without until it's a crisis situation. Then it just really taxes the whole system because the costs are just outrageous at that point. When we're talking about the uninsured, I always love to point out, that many uninsured are very, very hardworking people in our community. And in Montana, 171,000, and that statistic's actually a couple years old. It was the most recent one I could find. Like I say, I'm sure that's gone up in the last couple of months. But 92% have high school degrees. 77% are employed, but 70% live above the poverty level. So they're in that, between that 100 and 200, and in Missoula economics, it's tough to make it in that category. So it's not the people that you necessarily see on the street, but it's our neighbors. It's people that we see in the grocery store every day. So what types of programs do we have? And really our core services are our primary medical care, our dental care, and of course our pharmacy. Throughout our entire organizations, I always like to emphasize that we have a huge quality component that we're supposed to have in place for the federal government, and that we do have in place, a quality improvement programs. So that's very important that you're always improving, reporting that to the board, reporting it to our consumer users to make sure that that's in place and what they want. In our primary medical care, in fiscal year 2008, so that ended last June 30th, they had 18,434 encounters or patient visits. Their most common diagnoses were hypertension, depression, and we'll talk about mental health in a little bit here, and diabetes. We're staffed with 3 physicians right now and 2 mid-level providers. And by mid-level, I mean nurse practitioners and physician assistants. And then we have a variety of other volunteer physicians in our community who are fabulous, who offer specialty clinics in our organization. So oncologists, OBGYN, urologists that come in and support our providers on the next step or whatever needs to be done. We also have an asthma educator through a partnership with the University of Montana. We have medical case management and a referral program. If we have an issue that we can't deal with in the primary care setting, we do ask the doctors in our community who are specialists to see a patient at reduced costs, or at least that first initial visit, and work with them in hoping to set up Medicaid or Medicare or something like that to get their needs taken care of. The medical community is very generous to our patients in helping us out with that if we can't deal with it in the primary care setting. Most recently, I highlighted a couple of programs. We've implemented a pediatrics program, which we call the Partnership Panda program. Again, that is an incentive-based program that is building a relationship with our parents and our providers and focuses heavily on prevention. So that is through a grant that we're able to reward people for. They have all their immunizations, they have their kids' wild child's up to date. They're bettering themselves with education. They are able to receive incentives for that. We also have the Geriatrics Assessment Clinic, and this is in part response to some of the patients that need help with Medicare or who don't have access. And what we have done there, that was sponsored through a grant from the Gallagher Foundation, and it's a multidisciplinary program. We open up on a Saturday, and we have patients that come in and that are elderly patients, and we do a full assessment. They're actually there for several hours in the morning, but before they get there, we have our clinic RN goes out to their home, kind of sees what their situation is, talks to their caregivers or their family members, kind of sees where they are. Then they come in. We have our clinical pharmacists look at all of their drugs or all of their interactions. We have dietitians there, a full, complete assessment of the patients. The Saturdays work great because they don't have to navigate the craziness of during the week. to get that all done. We do that for our patients as well as for other physicians out in the community with the hope that they'll have a full assessment and better be able to take care of those patients. It's really important because in a private practice setting, doctors just don't have 2 and 3 hours to get that whole thing done. So it's really our way of partnering with the community to really help take care of the Medicare patients, a huge need that we see coming. In our dental clinic, last year we had about 9,000 encounters. We do emergency dental care, primary preventative care, and restorative. The interesting thing about dental care in Missoula, a statistic that many of us don't recognize is the federal government has designated areas that they call, that they assign certain communities based on their poverty level, access to care, Medicaid rates, that type of thing. And they rate it on a scale of 1 to 25. And if you have a 25, it means that access to dental care for low income in your community is very poor, very, very poor. And believe it or not, Missoula County has a score of 26. It's actually over the chart. It's one of 3 counties in the entire nation that has that score. It's amazing, yeah. So I can tell you, every day in the dental clinic, we have 3 dentists and we have a hygienist. People are literally pounding at the doors. We get there in the morning, there's probably 10 people who are in an emergency situation who are in pain and need to be seen that day. And our dentists, of course, always try to fit them in based on, no-shows and but they also have full schedules that they take care of. Of course, we try to really push the prevention so they don't get in that type of a situation, or in worst case scenarios, they end up in our medical clinic with dental issues too. We are very fortunate. We have 6 dental operatories. We just received a grant from the state of Montana for 3 more. So we'll be up to 9 chairs, which will be fabulous. And we'll keep them all really busy. We also have a Miles for Healthy Smiles program. That is a grant-funded program, that is a program that actually goes out into the schools and provides oral health education and then screens children. Focus there would be the Medicaid and the CHIP children. And again, prevention, teach them how to brush their teeth, how to floss, get that done, kind of break those habits at a young age. We do lots of screening. And if we find a child that has some issues, then we bring them into our clinic and have follow-up treatment and work with the patients in the schools so that access and cost is not a barrier. We target the low-income schools there. Sealy, DeSmet, Lowell, those schools have been used. Our pharmacy, you can see there, they're very, very busy. Last year, they filled over 46,000 prescriptions. So very, very, very busy. We do yep?
In terms of the alcohol dependent, do you have a naltrexone program?
We don't at this point.
Okay. Naltrexone program. It's a, you know what I'm talking about.
Yes.
As long as she knows, we're all okay.
Yeah,
We'll talk.
Yes, great, yes. Yeah, and we'll cover some of that in sort of our future growth too.
Okay.
Yeah, on some of our needs. We do participate in what we call a 340B program, and that is we're a federal program where we're allowed to purchase prescriptions at a reduced cost. So we're able to pass those costs on to our patients. So our prescriptions, we don't have a flat fee for them. We have an admin fee and then a fee based on the cost of the drug is how we cover those, but hugely reduced for patients. Even lower than the Walmart costs that you see. So they do an excellent job in the pharmacy down there. Approximately 12% of our prescriptions are for the homeless. So, yeah. Some of our other programs that I've just touched on a little bit, I'll go into a little more detail, we have a Ryan White program that focuses on HIV or AIDS individuals, healthcare for the homeless, the Montana Breast and Cervical Health, and our Access to Therapy program. For the HIV program, that's also a federal grant. We cover the entire western part of Montana. So we have 18 counties in there. And we have case managers set up in strategic locations to help them get their pharmacy, housing referrals, transportation, but mostly their medical care. Healthcare for the homeless. Case manager who works very closely with all of the homeless. We also have established a clinic at the Poverello Center that is staffed by a provider and a nurse down there. So that works out very well with the homeless. It's really important that you establish that relationship with them. If we have issues that can't be dealt with down at the Poverello or are dental related, we just bring them right down to our clinic and get them in through that way. Our breast and cervical program, low-cost mammograms, breast exams, and PAPs for women who are 50 years or are older. Our access to therapy program, this is a very, very creative program, and as many of you are probably all aware, healthcare in the mental health care in the United States is just in a horrible situation right now in terms of access, in terms of providers, in terms of dealing with it appropriately. It's not uncommon for us to just have a patient discharged from Warm Springs with their outpatient plan to show up at Partnership Health Center with prescriptions for thousands and thousands of dollars worth of drugs that are very difficult for any organization to fulfill, and that we can't always meet that need. What we have tried to do to work with our patients, Partnership Health Center patients, is we have a program that is sponsored through the city of Missoula, also from St. Pat's Hospital, and we've received money from a First Interstate Bank grant that have helped that program. But we have a relationship with the University of Montana and a school out of Coeur d'Alene, where we bring postgraduate students that are working on their master's or their education. And we pay for their supervision. They have to have a certain number of hours that are supervised before they can actually be certified. So in that environment, it provides counseling for all of our patients while we're developing counselors in the future, and hopefully that like to work with our population. A lot of times, our patients just need someone to talk to. They're not in a huge, they're just in a mini crisis. They just need someone to get them through it, 4 or 5 sessions to talk to or a game plan to have. And that's really what we focus on in this program, is the short-term counseling. We have submitted a request for a mental health expansion grant, and we've had tremendous support from the city of Missoula, from everybody in the city and everyone in the county for that grant that would actually provide more specialists, some of the programs that we were alluding to, a licensed addiction counselor. So we're keeping our fingers crossed on that. We'll know in August whether we'll have that. But the mental health in our state and in our country is something that has been ignored for a long time and is really in a crisis type situation. None of Partnership Health Center would be possible without all of our partners. The local physicians, the hospitals actually provide financial support to Partnership Health Center. It's in their best interest for their patients to come to us as opposed to going to the emergency rooms, which isn't the appropriate place, and to get them to establish primary care. The city and the county, United Way. We work with many local foundations. I've talked about some of them today, the Gallagher Foundation, the Chutney Foundation, First Interstate Bank, very, very generous community. Holy Spirit Parish, it's very interesting. I mentioned that we had physicians and providers that volunteered. Actually, at Partnership, we have more volunteers than we have staff. We have over 61 volunteers. Holy Spirit Parish is one of those areas that has actually adopted Partnership Health Center. We have volunteers intertwined through our entire organization at that provider level, down to calling patients for their next day appointments, to pulling charts, to helping us do any filing. Anyone that volunteers, we can find a job for them. And we depend heavily on that, and we leverage against those resources for our grants and for the federal funding that we get. So it started with all of the volunteers, and we still are very heavily dependent on them and couldn't do what we do today without them. They greet in our lobby. They're just all over our organization. One of the things, my last slide, is what's next for Partnership Health Center. And as I have alluded to, the demand for our services is huge. I told you about the dental clinic, but in our primary care clinic, we've tracked and have done studies, and we have over 50 phone calls a week for individuals who are trying to access primary care or to get an appointment. Our patients on a patient appointment can sometimes take up to 4 weeks or 6 weeks, and sometimes that's not soon enough for people. We have established a walk-in clinic to try and address some of the most urgent needs, and we do that every afternoon, and people are lining up for that. But we're in a perfect situation right now in that we have identified another location for Partnership Health Center to move to, which is about a block and a half away. And it's called the old Creamery building. And Red Cross is actually in that building right now. And it's more than twice the size of what we are right now, about 24,000 square feet. So we have been lucky in that with some stimulus funding, we're able to cover some of the remodeling costs for that. We're still working heavily on raising funds for the actual purchase of the building. The county, Missoula County, has been extremely supportive and has secured the building for us until we raise all of those funds. But we'll use the stimulus money to move our dental clinic over there right away. To add those other chairs, so we'll have 9 chairs. That will go on the top floor of that building. Because of finances and having a good business plan, it's a transition over a couple of years. So we'll spread out our pharmacy and our medical clinic in our existing building for a couple of years while we work on raising money, getting everything in line. And then the plan would be in June of 2011, start transitioning the rest of the organization over there. We love our building right now, but we would probably sell our building to help pay down debt to keep our business model in place and pay down the costs of the Creamery building. So we are working hard on that. It's exciting. We're positioning ourselves to continue to grow. When you're looking at federal grants or any grants, you have to look at sustainability, and that includes having providers, having a good business plan, and having a place where you can be. And Partnership Health Center is positioned right now perfectly for that. So, we're in a good shape. So that is about Partnership. I'm happy to answer any questions.
Do you have any idea how much of the need in the community you meet? I mean, do you look at census data or some other data to say, okay, there are this many people out there who could use us, we're only meeting 10% of that?
Yeah, I think we're meeting about 25% of the need right now, based on statistics from Montana Primary Care Association. Yeah?
2 questions.
Sure.
You're aware of the House Bill 130, 131, and 132 that just passed the legislature for community health services? And if the governor does indeed fund it, hopefully you'll apply.
Yes, absolutely. Yes.
Could you repeat the question, please? The sense of the question.
Yes, the legislation that just passed on some of the House bills that provide for some continuing health care benefits in our community. Mental health in particular, yeah. If the governor does elect to fund that in his budget, if we would foresee us participating in that, and most definitely, absolutely.
Dorothy and the Bozeman League were the ones that pushed this along with the coalition, so it's so overdue.
Very overdue, yes.
And we're delighted to take credit where Bozeman is due.
Yes.
How do you spell your last name?
MANSCH.
Okay.
Yeah.
How much of these health problems that you encounter among this group arise from malnutrition?
You know, we work closely with the health department for nutritionists. I would say that's not a huge percent that we see. We have caseworkers that identify any type of situation like that, and we do see in the elderly population if they're watching their dollars. Sometimes if it's medication, healthcare versus their home or food, they have to make some really hard choices. What we like to do for the medical case management when we have someone that's in a situation like that, we have that case manager work really closely with them and set them up with other resources, the food bank for women and children, over to WIC, of course, at the health department, those types of things. So our providers are very in tune to watch for that, and so we take every step that we can to avoid that.
If indeed the sky falls and the federal government actually makes changes, reforms in medical care, and so there will no longer be any uninsured, what kind of future do you see for partners in that scenario?
I think we're the perfect answer to help with that scenario. And I think the federal government sees that also. They have a huge investment in the infrastructure of community health centers. And what we have is providers that they need to deliver those services. And so since we've partnered with them so long, community health centers in particular have demonstrated some very, very important things. They do excellent for chronic disease management, and they statistically have proven that they're a cheaper model in delivering all of that. Again, that's a lot of the comprehensive care that you have all under one roof. You have your mental health, your medical, and your dental. So it just provides for the whole person, and a lot of times the whole family, healthier. So the model is a much more cost-effective model. So I think community health centers are where they're going to really look to provide a lot of those services.
I assume you have a good finance director now.
Yes, we do. Yes, her name's Doreen Boyer. She's fabulous.
I
Yes.
think that's excellent. Do you find that you have to then staff quite a few people in order to process all of the Medicaid, Medicare, and the fee issues? The way I see doctors' offices where there's a big group that are already taking care of insurance and records and things. So what is that?
Those are very expensive administrative costs that are tacked on to the healthcare system across the entire country. So for us, for those 10,000 patients right now, we have 3 full-time people that just look at trying to collect the payment, making sure things are billed the appropriate way. And keep in mind, that's with a patient load that 40%, we're only submitting claims for 40%. 60% is just a matter of getting statements. If we were submitting insurance for all of those people in our current system, it would be, you'd have to have at least twice that many people. And we could have another person, to make everyone's life more fun. But yeah, huge administrative burden. And just making sure that we get the payments.
Of these 10,000 patients that you have, how many do you find alcohol dependent or alcohol abuse, either in the families or the patient themselves?
High. I couldn't give you a huge, an exact number, but at least a quarter. Probably higher than that, which is probably what you see in the courts, or more so.
More so. It's very, very high population that really needs a better systems, better response, better treatment, better everything.
Right.
Does that include drugs, other drugs besides alcohol, or just alcohol?
Usually, well, I don't want to say that her clients are the same as my clients, because they're not, okay? But of the people that I see that have alcohol issues, depression is huge. And then self-medicating for depression. And then also the second highest drug of choice right now or of abuse is prescription drugs. It's not methamphetamine, it's not cocaine, it's
prescription drugs.
Here in Missoula.
Pain medication.
opiates. And what I alluded to naltrexone, because naltrexone is a drug that is used and it helps kill the urge to have alcohol, so that if people drink alcohol, it's not like they get violently ill, like one medication that's out there, they get violently ill. This naltrexone, they can't get drunk when they drink. That's what it does. Okay, they cannot get any pleasure out of drinking. And for somebody who really, really has an alcohol problem, that really, really wants to quit, that wants to quit, or even those that don't want to quit, and you get them into an alcohol court where you have what's called coercive treatment. That's what it's called. It's called coercive treatment, and it works. I mean, they have over 2,300 courts like this, and that's why I'm talking with her about naltrexone, because it's been shown to work in people who are in coercive treatment. They want to quit, and that urge is pulled away for a month, or maybe 60 days, or maybe 90 days, whatever they need, and then they can get on with their business because they finally clear their head of alcohol. You know, that's the first step.
Right, and the key to that, of course, is having the resources, and it's not just the drug, but it's
a very expensive drug.
Very expensive.
Very expensive.
That's the point.
Yeah.
You spend a lot of time on preventive care and preventive treatment. Do you have any way of measuring or even estimating what effect that has on your long-term patients' care? I mean, is prevention actually saving long-term
Yes.
serious chronic conditions?
Yes, and absolutely, and statistically not. We submit information as part of our federal grant. You know, you kind of have a lot of information you have to submit that tracks all of that. We don't do as much preventative care as we would like to because of the access issue, and a lot of people are sort of in crisis. In our dental clinic, for example, we have a 40 to 60% ratio, 40% preventative care and 60% that's really just emergency type care. So we track all of those statistics, but yes, when I was talking earlier about the preventative, the community health center, the chronic disease management is a cheaper delivery of care, and community health centers are right up there. As a matter of fact, I am kind of very, very encouraged. The state of Montana is starting to get on board with that too, and they actually have a new program out where for their Medicaid patients where they're going to place case managers for chronic disease patients right in community health centers. And so those patients will have a direct case manager that will work with them on that preventative basis. It will take a couple years to see the results and the savings from that, but statistically it happens over and over. And the community health center has tracked that and really demonstrated that effectively.
One more quick question. How do you advertise in the community that you're available? How do people find you if they aren't connected to the usual kinds of...
We do patients surveys, and over 80% of our patients hear from us through word of mouth, from somebody that has been to partnership or with our partner agencies. So many people that are serving the same clientele or the same people that we see, they refer us, lots of referrals to us. We have not done extensive advertising out in the community because we couldn't serve all of those patients at this time. So.
Kim, I thought it was really neat. One day I was volunteering and you were doing physicals for all sports for $20. So all these kids were coming in and parents who might have some other idea about what it was. And I thought it was a real good way.
Yeah, we do provide sports physicals. It's hard for people to get that, and it's great when we have those kids come in. Of course, we want them doing that physical activity. So, and if there's a cost barrier, then we help them out with that too.
Kim, thank you so much. I think it's my job as the person who started the meeting to say formally that people who have to go may go. But Kim said she'd be delighted to stick around and have more questions. And thank you so much.
You bet. I love it. Thanks, you guys. Thank you.